This is a 24/7nursetutors.com lecture. 24/7 Nurse Tutors, providing unlimited tutoring.
Welcome, and thank you for joining us. Neurological System, Part 2.
Let's talk about what can happen when we have a neuro injury or surgery. Did you know water balance can get messed up? Yes, a disorder of sodium and water balance is a common complication following neurosurgery. Early detection is critical to the protection and integrity of the brain. With neuro injuries, the pituitary gland can get messed up. Where is the pituitary gland located? Well, look at the picture. Yeah, it's right there. The pituitary gland, also known as the master gland, can be affected when a patient has neural problems. The posterior pituitary secretes oxytocin and the antidiuretic hormone, also called vasopressin. ADH is produced in the hypothalamus, stored and released from the posterior pituitary gland. We will talk about oxytocin when we get to maternal newborn. Anytime you hear ADH, think water. Yes, water. Too much ADH and we have the syndrome of inappropriate ADH secretion, SIADH. The patient retains water. And when ADH is deficient, we have diabetes insipidus. Remember, in high doses, vasopressin vasoconstricts. In low doses, vasopressin conserves water. Do you know the highest ADH levels are around 11 p.m. to midnight? Yeah, that's right. Many of my students get confused with diabetes insipidus and diabetes mellitus. Here is an easy way to remember. What does diabetes mean? To siphon. What are you siphoning? Urine. What does mellitus mean? Sweet or honey. What does insipid mean? Tasteless. So if the urine is sweet or honeyed, guess what? Your patient has mellitus. Diabetes mellitus. And if the urine is tasteless, your patient has insipid diabetes insipidus. ADH, antidiuretic hormone, is a hormone made in the pituitary gland. ADH does what the name says. It stops urination. It stops diuresis. Slowing or stopping urine production leads to fluid retention. That in turn causes a dilution of body sodium. So fluid goes up, sodium value goes down. What causes SIADH? Well, let's say someone goes into shock. Guess what the body is going to do? Conserve the little it has. SIADH may be seen in a patient who has had volume loss of between 7 and 25%, which is hypovolemic shock. It could be due to trauma, pain, nicotine, stress, morphine. It could be drinking too much alcohol, especially beer, due to its hypotonicity and the fact that one usually drinks copious amounts. SIADH is treated by restricting water. Decreased water intake allows serum sodium level to rise normally. Now, what is the maximum amount of water a patient with SIADH is allowed to drink? Well, the amount of urine lost plus 500 mLs to account for insensible fluid losses. You need to restrict fluid intake 800 to 1,000 cc's per day. Daily weight with a strict intake and output. Monitor urine-specific gravity. 0.9 normal saline infusion is given to raise the serum sodium level if water intoxication is severe. Monitor for hyponatremia, and Lasix may be administered to block circulatory overload. Let's talk about the treatment for SIADH. The medication of choice for SIADH is dimethylcycline hydrochloride, or HCl. It interferes with the action of ADH. Lithium may be administered to block renal response to ADH. Tolvaptan, stimulating renal water reabsorption. Surgery and chemo to remove or destroy neoplasms that may be the underlying cause of this syndrome. Once again, dimethylcycline or declomycin and lithium. They're used for excess secretion of ADH or SIADH. The action is to inhibit ADH action in the kidneys, block renal response to ADH, and interfere with the action of ADH. The therapeutic outcome is decreased urine-specific gravity. Do you remember what I said about diabetes? What does diabetes mean in Latin? It means to siphon. What are you siphoning? Urine. What does mellitus mean in Latin? It means sweet or honey. What does insipid mean in Latin? It means tasteless. Good job, you remembered. So if the urine is sweet or honeyed, guess what? Your patient has diabetes mellitus. And if the urine is tasteless, your patient has insipid diabetes insipidus. Now, diabetes insipidus is an uncommon syndrome of the posterior pituitary hypofunction. It is a disorder of water balance caused by the non-osmotic renal loss of water leading to the excretion of large volume of dilute urine. Can you guess how many liters of urine a day is secreted? Tons and tons of urine. Between 4 and 18 liters per day. Now that's a lot of fluid loss. When you have a patient losing, let's say, 15 liters of urine per day, what are you worried about? This patient could go into shock. Yes, shock. Vascular collapse. The urine-specific gravity is usually less than 1.005. Most cases occur in adulthood, while nephrogenic and familial forms are seen in kids. The good news is that diabetes insipidus is rare. It is an uncommon syndrome of the posterior pituitary hypofunction. Signs and symptoms include increased thirst or polydipsia and increased urination, polyuria. It results from ADH, vasopressin deficiency, which prevents the kidneys from reabsorbing water. It's the inability to conserve water. Etiology could be familial or idiopathic, a head injury, neurosurgery, or damage to the hypothalamic areas that produce ADH. Diabetes insipidus is usually diagnosed by a fluid deprivation test. Now with this test, the patient is required for a prolonged period to forego intake of water completely. This is to determine the cause of the thirst. This test measures changes in body weight, urine output, and urine composition when fluids are withheld. Or there could be a history and examination. The fluid deprivation test, vasopressin challenge test, 24 hours urine, high sodium in the blood, an MRI of the pituitary, hypothalamus, and skull to see damaged areas. The causes could be a lesion on the hypothalamus which interferes with ADH synthesis, transport, and release. It could be a brain tumor, a pituitary cranial surgery, head trauma, CNS infection, vascular disease. The treatment, intravenous fluids, hypertonic saline IV, extracellular solution to pull fluid from outside the cell to inside the cell, vasopressin, either SCIM IV or a nasal prep, a long-term DDAVP, desmopressin, nasal prep, with an analog ADH, diabetes insipidus treatments, vasopressin, pitressin is ADH. The classification is a hormone or a diuretic. Uses of the treatment of central diabetes insipidus due to deficient antidiuretic hormone. The dose and the route, intramuscular or a nasal spray. And you must remember to replace fluid, saline and glucose, monitor intake and output, check specific gravity, observe electrolytes, and monitor adverse reactions such as abdominal cramps, angina, or myocardial infarction. The Glasgow Coma Scale helps to gauge the severity
Let's
of
talk
an
about
acute
another
brain
tool
injury.
that we use
It
when
tells
we
us the
are
level of
assessing our neuro
consciousness of a
patients.
patient. It
It's
looks
the
at
Glasgow Coma
eyes 4,
Scale. It is the
verbal 5,
consciousness scale.
movement 6.
I remember
We
when
will
I
have a
was
picture of the
in
GCS
neuro,
on
I
the next
worked in
page.
neuro
The
many
minimum
years, and
score is
I
3.
remember
The
all I
maximum score
wanted to
is
know,
15.
hey, they all
I
came in
have a
with
question.
SAH,
How low
SDH,
would the
MVA,
GCS
they were in the
be that your
MVA,
client
status
would probably
prosopranine.
be
I
intubated?
knew that, but guess what? I wanted to know the
Less
GCS.
than 8,
It tells me a
intubate.
lot about
Remember that
how
little
my
rhyme.
day is going
Less
to
than
go.
8, intubate. A
Class.
score of 7 or less,
It
coma.
starts with,
A
it
score
looks
of
at
3
the
to
eye
4, well,
movement,
that's a high
verbal,
mortality rate.
and movement.
There are other
Write
signs of
that
altered
down.
level of
Eyes,
consciousness, like
4,
change in size and
verbal,
response of the
5,
pupils, which
movement,
dilate on the
6.
side of injury initially,
I say it
elevated
again.
temperature,
Eyes, 4,
and the
verbal,
Cheney-Stokes
5, and
respiration,
movement, 6.
hyperapnea, and
And
apnea.
eyes, remember that the minimum number is 1 and the maximum is the 4, 5, or 6. So the maximum score for the GCS is 15 and the minimum score is 3. Remember that if that score, the GCS, is less than 8, they're probably going to intubate. So write that down. Less than 8, intubate. Less than 8, intubate. A score of 7 or less indicates coma, and a 3 or 4 is not a good score. Why? Because it's almost like a 0, isn't it? It's right there at the minimum, 3 or 4 high mortality rate. Other changes we may see with a patient that has an altered state of consciousness is a change in the size or response of pupils. That's why we do our perla. We may see one side is dilated, the side of the injury. We may see an elevated temperature. Remember, our Cushing's triad will always be the first thing you're looking at. We may even see Cheney-Stokes respiration. And what is Cheney-Stokes, class? What is Cheney-Stokes respiration? I heard some of you say death, yes. What do we see? We see fast breathing, and then they do what? They stop. Apnea. Fast, and then they stop. Fast, and then they stop. That can be a very, very scary time for the family. So you as a nurse, we want you to support that family. Okay? They stop breathing, apnea.
Here's a picture of the Glasgow Coma Scale, which measures the following functions. Eye opening, that's E. 4 is spontaneous, 3 to voice, 2 to pain, 1 none. Verbal response, or V. 5 normal conversation, 4 disoriented conversation, 3 words but not coherent, 2 no words, only sounds, 1 none. For motor response, or M, 6 is normal, 5 localized to pain, 4 withdrawals to pain, 3 decorticate posture, an abnormal posture that can include rigidity, clenched fists, legs held out straight, and arms bent inward toward the body with the wrist and fingers bent and held on the chest. 2 decerebrate posture, an abnormal posture that can include rigidity, arms and legs held straight out, and toes pointed downward, the head and neck are arched backward, and 1 none. Here's a picture of the Glasgow Coma Scale, which measures the following functions. Eye opening, That's E. 4 is spontaneous. 3 to voice. 2 to pain. 1 none. Verbal response, or V. 5 normal conversation. 4 disoriented conversation. 3 words but not coherent. 2 no words, only sounds. 1 none. For motor response, or M, 6 is normal. 5 localized to pain. 4 withdrawals to pain. 3 decorticate posture, an abnormal posture that can include rigidity, clenched fists, legs held out straight, and arms bent inward toward the body with the wrist and fingers bent and held on the chest. 2 decerebrate posture, an abnormal posture that can include rigidity, arms and legs held straight out, and toes pointed downward. The head and neck are arched backward. And 1 none. We know with neuro patients we have to
We
suction
also know
them.
with our neuro
Why do
patients,
we
we
suction
have
them?
to suction them. Why
It
do we
helps
suction
prevent.
them?
Go ahead
It
and tell
helps
me.
prevent.
It helps prevent what?
Go ahead, tell me. It helps prevent what?
Aspiration. Very good. It helps
Aspiration. Very
prevent
good. It helps
aspiration. And
prevent
why would you like to
aspiration.
prevent your patient
And
from
why would you
aspirating?
want to prevent your patient from
Of
aspirating?
course, because they could get
Of course, because they can get pneumonia.
For treatment,
They can get
we'll intracranial
pneumonia.
pressure monitoring, hyperosmotic
Aspiration
agents,
pneumonia.
20% mannitol,
Remember that there are
steroids
other
such as
ways to prevent
Decadron and
aspiration.
Solumedrol,
Elevate the
barbiturates
head of the
such as
bed
pentobarbital, and
before and
Dilantin,
after
and the
meals. This is
diuretics
extremely
are
important.
alternated with
Make sure your
mannitol.
patient can swallow. Did they fail a swallow test? If they did, guess what? Nope, they should be NPO, shouldn't they? Yes, make sure they are NPO. Make sure you inform the physician or the healthcare provider. Make sure they know. And anytime we suction, remember we're going to hyperventilate this patient before and after with how many % oxygen? Very good. 100% oxygen. Please hyperventilate before and after suctioning with 100% oxygen. And we always limit suctioning to how many seconds? 10 to 15 seconds. 10 to 15 seconds. I always tell my students, hey, when you put that tube down, put it down, and guess what? Hold your breath. When you can't breathe anymore, well, you need to start bringing it out. Remember, we do it in a twirling motion and bring it out. We always want to keep the airway free of secretions to prevent aspiration. Treatment. Let's look at treatment for our patient that has increased ICP. Of course, we're going to do ICP monitoring. This is normally done in the ICU. Hyperosmotic agents are usually used as well, like 20% mannitol. It's normally alternated with diuretics. Steroids are used, like Decadron, like Solumedrol. Barbiturates are used as well. Dilantin is used. Remember with Dilantin, what is one of the side effects of Dilantin? Make a guess. Something to do with the gums. Very good. Gingival hyperplasia. I'll say it again. Gingival hyperplasia. Gingival, G-I-N-G-I-V-A-L. Then hyperplasia, H-Y-P-E-R-P-L-A-S-I-A. Gingival hyperplasia. Remember that diuretics are usually alternated with mannitol.
Now let's talk about a cerebral vascular accident or stroke. There are two types of CVAs, an ischemic stroke and a hemorrhagic stroke. One is caused by the rupture of a weakened blood vessel or an obstruction. Which one is which? Hey, the name alone gives it away. Hemorrhagic means bleeding, and with the ischemic stroke, there is a blockage. A stroke is basically caused by a disruption of the normal blood supply to the brain. The mortality rate for stroke is high. That's why we need to act fast. Yes, act fast. Remember, recovery from a hemorrhagic stroke is usually better than an ischemic stroke. So what is a hemorrhagic stroke? A hemorrhagic stroke may result from an aneurysm, a rupture of the AV malformation, or even severe hypertension. It has a sudden onset. What are the signs and symptoms we may see? Your patient may go into a coma. Their blood pressure may shoot up. Do you think we may possibly see focal deficits? Oh yes. How about seizures? Yes, very possible. Could there be permanent deficits? Yes. Let's talk about an ischemic stroke. What is an ischemic stroke? Well, an ischemic stroke is caused by a blockage of a blood vessel, generally caused by atherosclerosis. Early warning signs include transient loss of vision, transient ischemic attack, which is a brief interruption in cerebral blood flow. Yes, a TIA is only saying, hey, watch out, the big one could be coming. It usually resolves within 24 hours. And your patient says, okay, thank you, Lord. Remember, ischemic strokes are often preceded by warning signs such as TIAs. So what are the risk factors for an ischemic stroke? Atrial fibrillation, ASHD, cocaine use or abuse, a history of blood clots, or TIAs. We need to keep the blood pressure low with a hemorrhagic stroke. Why? Blood pressure? Pressure on the blood? What could happen? Yes, more bleeding, because the patient had a hemorrhagic stroke. The treatment for a stroke is to give the clot buster, like tissue plasminogen activator or streptokinase. Now there are contraindications to tissue plasminogen activator, but in general, which of my patients can get the TPA? The one with a hemorrhagic stroke or the one with an ischemic stroke? Think. We know TPA is a clot buster and will make our patients bleed. So if we give it to a patient who has a hemorrhagic stroke and is already bleeding, what is going to happen? My patient's going to bleed more, and we don't want that. So guess what the patient with an ischemic stroke is the better candidate for? Right, the TPA. Now what is the window of opportunity to TPA a client who has had a stroke? Well, it's 3 to 4.5 hours. What if it was a myocardial infarction? What is the window of opportunity to TPA a myocardial infarction? 6 hours. I like to keep things together, so remember two numbers with TPA, 3 and 6. 3 for the head, 6 for the heart. The shorter time for the stroke, because time lost, is brain loss. Tissue plasminogen activator is contraindicated for those who have subarachnoid hematoma, a previous stroke, if the patient is currently on anticoagulants, has uncontrolled hypertension, has a seizure at stroke onset, or is bleeding. Don't forget with a stroke, time lost is brain lost, so we need to act fast. When your teacher took you for clinicals, do you remember seeing the big FAST sign in the lobby? Many hospitals around the nation have the FAST sign in their hospital lobby. I know your teacher told you about FAST, so tell me, what do the words FAST in relation to stroke mean? This acronym stands for F for facial drooping, a section of the face, usually only on one side, that droops. This can be recognized by a crooked smile. A is for arm weakness, the inability to raise one arm fully. S is for speech difficulties, an inability or difficulty to understand or produce speech. And T is for time. If any of the symptoms above are showing, time is of the essence. Call the emergency services or go to the hospital. There are both modifiable and non-modifiable factors that can cause a stroke. Can you name them? Heart disease, diabetes mellitus, arterial fibrillation. Yes. And I know your teacher told you AFib throws clots. Yes, AFib throws clots, and we'll discuss more about this in the cardiac lecture. How about hypercholesterolemia? Could that cause a stroke? Oh yes. So can hypercoagulable states and the use of cocaine or illicit drug use. How about obesity? Can obesity cause a stroke? Yes, it can. So you need to encourage your patients to lose weight. By the way, what is the BMI range for someone who is obese? 30 to 39.9, that's right. A BMI of 30 to 39.9 is obesity. And morbid obesity is a BMI greater than 40. So what is the normal BMI? 18.5 to 24.9. We'll discuss more weight and BMI when we talk about the metabolic syndrome. There are different types of headaches like sinus, cluster, tension, and migraine headaches. Now, sinus headaches, the pain is usually behind the forehead and or in the cheekbones. For a cluster headache, the pain is in and around one eye. For tension, pain is like a band squeezing the head. And for migraine headaches, there's pain, nausea, and visual changes are typical of the classic form. Migraines are caused by a phenomenon called cortical spreading depression, whereby neurological activity is depressed over a specific area of the cortex, formerly felt to be related to dilation of the cerebral blood vessels. This results in a release of inflammatory mediators leading to irritation of the nerve roots, especially the trigeminal nerve. Serotonin releases, and that involves the causation. Diagnosis is based on a history and physical exam, a neurological exam, and imaging. What can trigger a migraine? Well, tyramine-containing foods and beverages like beer, wine, aged cheese, chocolate, yeast, MSG, nitrates, artificial sweeteners, smoked fish, and any kind of aged or fermented foods. Medications like estrogens, nitroglycerin, nifedipine, cimetidine. Other causes of a migraine include fatigue, hormonal fluctuations, missed meals, sleeping problems, and even varying altitudes. Medications used for a migraine include NSAIDs, beta blockers such as Inderal, calcium channel blockers like verapamil, ASA, acetaminophen, triptans like sumatriptan, ergotamine, and opioids. Let's discuss seizures. A seizure is an abnormal, sudden, excessive, uncontrolled electrical discharge of neurons within the brain. This may cause a change in level of consciousness, motor or sensory ability, and behavior. A person is diagnosed with epilepsy when they have had 2 or more seizures. Epilepsy is an abnormal electrical disturbance in 1 or more areas of the brain. Most people afflicted with epilepsy are under 20 years of age. The basic problem is thought to be an electrical disturbance in the nerve cells in one section of the brain, causing them to give off abnormal, recurrent, uncontrolled electrical discharges that produce a seizure or convulsion. The underlying disorder may be structural, chemical, physiological, or a combination of all 3. Seizures can be generalized or partial. Generalized, as the name implies, involves the entire brain, while partial seizures originate in one part of the brain. There are different types of generalized seizures, namely absence, this used to be called the petit mal, commonly seen in kids. Tonic-clonic, used to be called a grand mal, muscle stiffening followed by jerking. Myoclonic, here we have contractions of the body muscles. Tonic, the muscles stiffen. The patients may lose consciousness and fall down. Atonic, these are those people that suddenly go limp or have a drop attack. There are different types of partial seizures, namely a simple partial seizure. We may see jerking, muscle rigidity, spasms, head turning, unusual sensations affecting either the vision, hearing, smell, taste, or touch, and they may have memory or emotional disturbances. And there's complex partial seizures. We may see automatism such as lip smacking, chewing, fidgeting, walking, and other repetitive, involuntary, but coordinated movements. Let's say you just finished shopping for drinks at Walmart. A brand new graduate nurse waiting to take the NCLEX, buying drinks for your graduation party. Yes! And I know you're probably thinking about normal lab values, erythroblastosis fetalis, and planning your party, right? Well, you're loading up your car, and you turn to admire a cute little girl in the car beside yours, whose mother is loading her car up as well. The little girl is giggling and singing her favorite nursery rhyme. Mommy, listen. Ring around the rosy, a pocket full of posies. Ashton, Ashton, we all fall down. You smile as you have flashbacks of Mrs. Brown, your favorite kindergarten teacher, teaching you that nursery rhyme. And then suddenly, boom! Her mom hits the floor. A massive tonic-clonic seizure. Whoa! Ooh! Oh my word! What are you going to do? You are the closest to her. So you run quickly over to help. And then what do? Oh my word! She is thrashing and knocking her head on the floor. Graduate nurse, what do you do in a Walmart parking lot to help this lady? Well, here's what you do. You think safety. Safety, safety, You're going to put a stick in her mouth to prevent her from swallowing her tongue. and prevent an airway obstruction. Oh, we won't? Your teacher rightfully told you never, ever, ever put anything into a person's mouth. Not even medicine, not even liquid. These can cause choking or damage to the person's jaw, tongue, or teeth. Contrary to widespread belief, people cannot swallow their tongues during a seizure. So, you roll the person on her side to prevent choking on any fluids or vomit. You cushion her head. How? You're not in the hospital. Get something. Get your jacket. Turn it into a makeshift pillow. Loosen any tight clothing from around her neck. Keep the person's airway open. If necessary, grip her jaw gently and tilt her head back. Do not restrict her from moving unless she is in danger. Remove any sharp or solid objects that the person might hit during her seizure. Note how long the seizure lasts and what symptoms occurred so you can tell the emergency personnel if necessary. So what information will you document? The facts. The F-A-C-T-S. Focus. What part of the body? Activity. Was it tonic? Was it clonic? Was it both? Color. What color was she? Did she become cyanotic? Time. How long was the episode? How long did the seizure last? How much time between episodes? Somnolence. What was her postcidal state? Or was there any secondary trauma? Was the seizure caused by a trauma? Did the patient suffer trauma as a result of the episode? Stay with the person until the seizure ends. In the hospital, medications that could be given include Dilantin, clonazepam, Klonopin, valproic acid, Depakine, or carbamazepine, Tegretol. Let's talk about anti-epileptic drugs. Tegretol is for partial or generalized seizures. Klonopin is for absence, myoclonic, and akinetic seizures. Valium is given for status epilepticus. We'll discuss that on the next page. Depakote can be given for all types of epileptic seizures. Zerontin is for absence seizures. Neurontin is given for partial seizures. Dilantin is good for all types of seizures. Topamax is given for intractable partial seizures. And Keppra is an adjunct in partial seizures. If medication is not effective, the neurologist may recommend brain surgery, like resective surgery, multiple subpial transection, hemispherectomy, or corpus callosotomy. Status epilepticus is a medical emergency, characterized by prolonged seizures lasting more than 5 minutes or repeated seizures over the course of 30 minutes. Brain damage and death can ensue. Left untreated, it can cause hypoxia, hypotension, hypoglycemia, dysrhythmias, and lactic acidosis. Rhabdomyolysis can occur with effects on the kidneys. Lorazepam is a drug of choice due to rapid onset of action and long duration of action. Other medications that may be given are Valium, phenobarbital, Dilantin. As nurses, we must provide supportive care. Remember, you are more than a conqueror and you will be successful. Join me as we review core content in the next unit.